Thank you for your kindly introduction, and thank you for having me in this conference. Actually, my assigned topic is sleep disorder in Parkinsonism, but as you have learned the daytime management of Parkinson's disease, so today I would like to cover most of the sleep disorder in Parkinson's disease, not only the Parkinsonism. But first of all, you have to know that Parkinsonism is not equal to Parkinson's disease. So when we are, according to the etiology classification, idiopathic Parkinson's disease is the most common cause of Parkinsonism. The second group is the secondary group, like drug-induced Parkinsonism, normal pressure hydrocephalus. The third one is the Parkinsonism plus or atypical Parkinsonism. For example, the MSA, multiple system atrophy, which is the Parkinsonism plus autonomic dysfunction. In PSP is Parkinsonism plus the supranuclear gait palsy. And the fourth one is the hereditary disease. But today we will cover most of the sleep disorder in idiopathic Parkinson's disease. Okay, let's look at the basic knowledge of the sleep, normal sleep physiology. For the macro sleep structure, we usually have the state N1, N2, and N3, and then go to REM sleep for each sleep cycle. And then for one sleep cycle, it takes around 90 minutes to 100 minutes per cycle. And for the whole night, we have around 3 to 5 cycles. And when the night passes, the REM usually get longer and longer, and in the morning is the longest part of the REM sleep. So when we focus to the sleep disorder, the sleep staging is one of the important part that you have to know, that because each sleep cycle occur in different sleep staging. And for when we focus about the EMG, the highest EMG we found in awake, and then it's progressively decreased from N1, N2, N3, and then absent in REM sleep. This is the normal physiology of the sleep. And because of the sleep regulation and also degeneration in Parkinsonism, they share the same anatomical localization. So Parkinsonian patients also have the sleep presentation. According to the ICSD-3, they classify the sleep disorder into 7 subclasses, from insomnia to sleep-related disorder. But today I won't cover only the sleep disorder. I will cover through the other nocturnal problem in Parkinson's disease. And for the prevalence of the sleep disorder in neurodegenerative, the most common sleep problem is insomnia. As you can see from this slide, we can find insomnia around up to 50% in Parkinson's disease at the early stage. But when they progress to Parkinson's disease with dementia in the advanced stage, it might be up to 70%. And also, we can find another sleep-wake disorder that is quite important as the new prodromal biomarker of the neurodegenerative disease is the excessive daytime sleepiness. We found nearly 70% in Parkinson's disease. And the second one is the parasomnia. Parasomnia is the abnormal nocturnal water behavior. It's like it's not only the movement, it's called behavior because it's more complex than the simple movement. And it can occur both non-REM and REM sleep. In non-REM, parasomnia is characterized, look like the daytime behavior. For example, sleepwalking, sleep eating, that I won't cover in this topic today. But I will cover the hallmark of the REM parasomnia, which is the RBD that we will talk later. And another sleep disorder that we can find in neurodegenerative is the sleep breathing disorder and RLS. But today we'll focus about Parkinson's disease. Again, the third time of this slide, as I showed the natural history of the Parkinson's disease from the prodromal, and now we have the new proposed natural history that before the prodromal state, there are the preclinical state, that is the change of the only biomarker without the clinical presentation, and the other, as you have learned from two previous speakers. When we focus about the sleep, when sleep occur in the PD lifetime. So the answer is should be it occur in every stage of Parkinson's disease from the prodromal state, as you will see that RBD or REM sleep behavior disorder can be found more than 5 to 10, sometimes more than 20 years before the onset of motor symptom. And in the prodromal state, they have another sleep problem like excessive daytime sleepiness, insomnia, and when disease progress, they have more another sleep problem like nocturnal hypokinesia or other non-motor feature that predominant in sleep, like impulse control disorder that you have learned from the first speaker. It actually the circadian rhythm disorder that usually present in the nighttime. And for the evolution of sleep disorder, actually is have the bidirectional association between the sleep, neurodegenerative process, the medication effect, and also the off state of the motor symptom and non-motor symptom of the Parkinson's disease. This is also from our Professor Pitayasirik review about the spectrum of the movement sleep disorder during the night and the association between the factor that influence each sleep problem. You will see that one sleep problem can be influenced from various factors like RBD, based on from the neurodegenerative, but sometimes it can be precipitated by the medication effect. So this is the whole spectrum of the sleep problem in Parkinson's disease. And during the whole night, there are also different sleep disorders in the different time because of, as I told you that during the night we have different sleep staging. So it depend on the predominance of each sleep disorder on each sleep staging. For example, for the first half of the night, we are predominantly in the non-REM sleep. So usually found the problem of the non-REM sleep disorder, any parasomnia or other sleep-related disorder that prominent in the non-REM. But the second half of the night, as I mentioned, that the REM sleep is get longer and longer. So the problem of the REM sleep usually occur in the second half of the night or in the morning. So the first problem that I will cover is the insomnia, which is the most common problem, sleep problem in Parkinson's disease. The definition of the insomnia is the difficulty in initiating sleep or difficulty in maintaining or early awakening, and it needs to accompany by the daytime function impairment. For the chronic insomnia, they need 3 times of this symptom per week and at least 3 months. For the Parkinson's disease, the characteristic of the insomnia is different from the general population. For the elderly general population, they usually complain about the sleep initiating problem, but in Parkinson's disease, they usually have the maintaining difficulty or sleep fragmentation and early awakening more than the general population. And as I mentioned, it can occur from the prodromal state. From the basic of sleep-wake mechanism, we have the process S or homeostatic drive, that it will be increased after we stay awake, and the circadian rhythm or process C that will increase when we sleep. So it both of process work well together, so it make the sleep-wake cycle normal. But if it impaired, this is one of the mechanism of insomnia in general population and also in Parkinson's disease. But for the pathomechanism of the insomnia in Parkinson's disease, it's believed that it's from the neurodegenerative change of dopaminergic neuron, and also it caused the loss of coordination of sleep state transition. So it makes sleep instability in Parkinson's disease more than the general population, and it can be from the dopaminergic medication that we treat for the daytime symptom. Another risk factor is for have an effect on insomnia and Parkinson's disease is the even motor and non-motor symptom that can have the presentation during the night as well, and other like mental health, behavioral, and also other sleep disorder that also have an effect on the sleep in Parkinson's disease. And how can we evaluate it? The gold standard still the clinical intervention that you will get the sleep schedule, duration, or sleep habit, and you can apply sleep diary to use in your clinic maybe 1 or 2 weeks before they come back for follow-up. And for the questionnaire, actually, we don't have the specific questionnaire for the insomnia in Parkinson's disease. You might use the insomnia severity index that can identify the insomnia. And the third one is the objective assessment. Actually, we don't need the polysomnography test for assessment of insomnia, except you suspect other sleep disorder like sleep breathing disorder or other sleep-related movement disorder. But now we have a new technology, which is the wearable sensor. The commercial one is the actigraphy that you can monitor the sleep and activity during the day. I will show you the example of the sleep fragmentation insomnia patient from the actigraphy result. The black one is the activity index, and the yellow bar is the right exposure, and the blue bar is the sleep duration. So you will see that they have a black bar in the blue zone. So it indicated patient have a fragment of sleep. So it can monitor maybe 1 or 2 weeks because this lasts long battery. For the insomnia management, the gold standard still be the non-pharmacological management, which is the cognitive behavioral therapy for insomnia. That is the very effective treatment, but it needs long time to change the cognitive and behavioral of the patient. And it's no side effects. So every insomnia patient should be sent to cognitive behavioral therapy if it's available in your country. And another non-pharmacological effect management is that have to promote sleep hygiene, promote exercise, and also bright light therapy. We are in the tropical country, so actually don't need the bright light device. So you can advise them to go outside to expose the sunlight in the morning and also in the late afternoon to regulate the regulation of the melatonin. So it can help in insomnia in this PD patient and also in general population. And for the pharmacological management, actually we don't have the clinical trial of specific medication for the insomnia in PD patient, but we adapt from the general population. And you need to rule out another comorbid during sleep, like sleep breathing disorder or sleep-related or PD-related motor and non-motor symptoms that can influence on the sleep. Okay, let's go to the next topic. This is also one of most common sleep problem next to the insomnia, which is the excessive daytime sleepiness. Actually, now we don't have the standard definition of the excessive daytime sleepiness, but we define as the inability to stay awake or alert during the day when the circadian rhythm drives promote alertness. And you might have seen both of these terms, excessive daytime sleepiness and sleep attack. Actually, it's not equal. For the excessive daytime sleepiness, it manifests like a gradual sleepiness and also sleep drift into sleep. You will feel like sleepiness, and sometimes patients complain about fatigue. But sleep attack, patient didn't feel any sleepy, that they will suddenly involuntarily into sleep onset, with usually associated with the dopamine agonist treatment. For the prevalence and the mechanism of pathomechanism of the excessive daytime sleepiness. It's usually based on the degeneration of the dopaminergic neuron and sleep regulation. We found that in PD patients, they have the lower amplitude of the melatonin rhythm for the whole day. That is one of the hypotheses that cause excessive daytime sleepiness, but actually the still caused from other like medication effect or other systemic problem. And one study found that if people napping during the day more than 1 hour, they will have a 2 times risk of developing of Parkinson's disease more than people who didn't have the excessive daytime sleepiness. So if you found someone who have the excessive daytime sleepiness during the day, one of the things that you need to consider is the probably neurodegenerative disease in the future. And as I mentioned, we can find from the prodromal, it's more prominent in the advanced stage. How can we assess it? In your clinic, you might be use the questionnaire like Epworth sleepiness scale. If the score more than 10 to 12 is indicate of the excessive daytime sleepiness. For the Parkinson specific questionnaire, we still don't have the specific for excessive daytime sleepiness, but you might need we have some item in PDSS2 and SCOPA that indicate the EDS. And for the objective assessment, it's quite difficult if you don't have the sleep specialist. You need to do the multiple sleep latency test. This is gold standard and more specific for the assessment of the EDS. And another differential diagnosis that you need to consider is when patient complain about look like EDS, might be he or she might have the fatigue or one of the wearing off phenomena of non-motor, and also the problem of the blood pressure like orthostatic hypotension or postprandial hypotension. And further management as this algorithm that I read, if you can evaluate the causative factor, and if patient have dopamine agonist, this is one of the most powerful medication that cause excessive daytime sleepiness in Parkinson's disease. So we try to reduce it, but you have to balance between the motor symptom and the effect of sleepiness from the dopamine agonist. And you have to be aware that if you reduce the dopamine agonist repetitively, it will be the occur of the withdrawal symptom from the dopamine agonist. So you need to slowly decrease of the dopamine agonist and balance between the motor symptom. And for non-pharmacological, it look like the insomnia management. And if it's still intractable, they have low of medication like modafinil or caffeine. Okay, so the third topic from this video, what is your provisional diagnosis? Who thinks A? Please raise your hand, please. Or B, or C, REM sleep behavior disorder, or D, restless leg. And so the answer from the front row is that is C. The answer is C, is REM sleep behavior disorder. You see the movement during sleep, that the jerky movement of the rim and the axial, and sometimes they have vocalization like shouting. And the polysomnography on the left show that the patient in rapid REM sleep stage, because you will see the rapid eye movement for the EOG tracing. But as I mentioned, that in REM sleep, the normal REM sleep usually atonia. This EMG activity or the purple line, we see the EMG activity. So this is the REM sleep behavior disorder. This is the hallmark of the REM parasomnia. Now, we found that RBD is one of the strongest and the highest risk of developing neurodegenerative disease in the synucleinopathy. And before this, before they develop the neurodegenerative, they only have the RBD. So the previous literature usually call this group is the idiopathic REM sleep behavior disorder. But actually when we follow them longer, maybe now we follow this group more than 10 years, and we found that most of them, nearly 90% turn to be the neurodegenerative group in the synucleinopathy, including Parkinson's disease, dementia with Lewy body, and multiple system atrophy. So the new literature try to change the term of the idiopathic to isolated RBD. So you might see both of term. It's still the same group, but try to use the new term of isolated instead of the idiopathic. And this is the criteria diagnosis for the RBD. I will show you what is the REM sleep without atonia. The upper tracing is the normal REM sleep. This is no EMG activity in REM sleep. But the lower tracing, you will see the abnormal EMG activity in the phasic. And sometimes you might see the tonic activity. This is indicate the abnormal EMG activity, so we call it the REM sleep without atonia. And there are a lot of definition of how many REM sleep without atonia to be diagnosis of RBD. Maybe it need to calculate from the whole tracing. The most common cut point is around 32% of the REM sleep without atonia to be the most likely of RBD. And when patient with Parkinson's disease has the RBD group, it usually found in non-tremor predominate and also have more postural instability more than PD without RBD, and have more excessive daytime sleepiness and also have more impaired cognition. As PD have a prodromal PD, in RBD also have a prodromal RBD as well. Back before the isolated RBD, we call it prodromal RBD, which is has an abnormal EMG activity that still doesn't meet the criteria of RBD. But when we follow up this group of prodromal RBD, most of them turn to isolated RBD in the future. So the prodromal RBD might be the earliest biomarker for the development of the alpha-synucleinopathy in the future. And in your clinic, you can identify RBD patient easily. If you don't have the polysomnography or sleep specialist, one thing that you can use is the sleep RBD questionnaire. The easiest one is the RBD1Q questionnaire. This is a yes/no question. You ask the patient or bed partner about, have you ever been told or suspected yourself to be seen acting out of dream while sleep? Like usually aggressive behavior like punching, folding your arm, or kicking or running, and usually associate with the dream content. And this is also another RBD questionnaire. For the treatment approach, the first thing that you need to consider is the safety of the patient and bed partner. So you need to ensure that the sleep environment is safety. You promote the sleep hygiene, discontinue any medication that might probably aggravate the RBD, like antidepressant, and treat other underlying cause like sleep breathing disorder that might aggregate or make sleep more fragment, and then if you have more fragmented sleep, you will go to more REM sleep, so then you have a lot of prominent RBD in patients with comorbid sleep breathing disorder. And for the pharmacological management, actually we don't have a true randomized control trial for the RBD treatment, but from the evidence that two drugs have the efficacy for reduce the dream enactment or the motor activity during sleep is clonazepam and melatonin. So the next topic is nocturia, a little bit about nocturnal problem. This nocturia is the waking patient need to waking to pass the urine during the night more than one time. We allow once during the night to be normal. So if they're going to pass the urine 2 times, 3 times during the night is the pathologic, we call nocturia. And the nocturia is one of the most frequent common nocturnal symptom in Parkinson's disease. Is when disease progresses, nearing 100% of the Parkinson have nocturia, and nocturia is also a common problem that cause sleep fragmentation in Parkinson's disease because they need to go to the toilet and then back to sleep, and they cannot go to sleep again. And in addition, nocturia that are quite prominent, usually associated with the autonomic dysfunction during the daytime. So if patient complain about frequent nocturia, you need to look for the daytime autonomic dysfunction like orthostatic hypotension, postprandial hypotension, and patient usually have the supine hypertension during the nighttime as well. And for the proposed mechanism of the nocturia still unclear, but we believe that it might be from the loss of inhibition of micturition defect from the degenerative of the dopaminergic pathway causing the hyperactive of the new bladder. So patient have to go to toilet many times during the night. The other mechanism might be nocturnal polyuria, and another is global uria. Nocturia is one of the most difficult problem to manage in Parkinson's disease. If you rule out the secondary cause or other systemic like cardiovascular, nephrology, urology, that also can cause the nocturia, and you cannot file it from Parkinson's disease. It's still no randomized control trial for the medication for the treatment of nocturia. You can only advise for the non-pharmacologic management, like you have to reduce the water intake in the late afternoon and go to the toilet before you going to bed, and reduce coffee or alcohol in the afternoon, avoid diuretic or antihypertensive during before night, before going bed, and head up position that around 30 degrees can help to reduce the nocturia. Very small problem. I don't touch it so much because it's the prevalence of the sleep breathing disorder in Parkinson's disease is quite the same as the general population. But if it have comorbid in Parkinson's disease, it might be make patient have more daytime sleepiness, more fatigue, and more impaired cognitive. Because we the new high propose that we believe that the glymphatic system or glymphatic dysfunction that we believe that is the one of the pathophysiology in Alzheimer's disease can also adapt to our Parkinson's disease, because it's also the accumulation of the abnormal protein in Alzheimer's is tau. In Parkinson's disease is alpha-synuclein. So during the nights that we sleep, the glymphatic system will work more than during the day to eliminate the waste product. But if they if the lymphatic system doesn't work well, so it might cause the sleep problem, and it might cause the accumulation of the alpha-synuclein and make the more inflammation. That might be one of the pathomechanism of the neurodegeneration. And the management is not different from general population. So move to the last one. What is this condition in this patient? A, B, C, or D? Before you go to sleep, you will see that patient is in his bed and try to turn their body, to move their body. This still working, video still working, doesn't stop, but patient cannot move their body. So this is, and the caregiver come to help him to get out of the bed. This condition is nocturnal hypokinesia, which is the difficult to turning or changing position during the night. But actually the spectrum and the range of the movement, nocturnal movement, nocturnal hypokinesia can range from the mild symptom to more severe, like pain during the night or cramp during the night, and mild early morning akinesia, difficulty in turning in bed, or morning dystonia that usually involve the lower limb, and at the end state they cannot move their body. Is called nocturnal akinesia. As you learn about the wearing off during the day, the nighttime also have the wearing off phenomena. For the night is the longest period that you didn't take the medication, so the nocturnal hypokinesia is maybe the longest wearing off of the day. And the early morning kinesia is one of the early manifestation of the wearing off. So if your patient has early morning complaint of difficulty of movement, so you have to be aware about the occurrence of wearing off. And physiology is still unclear, but it also from the degeneration of the dopaminergic, and the dopaminergic normally is the circadian rhythm as well. During the night, the dopamine still usually low during the night, and it might be more low from the degeneration. And the other factor is the aging process. For the assessment or evaluation, I would like to introduce some validate questionnaire of nocturnal hypokinesia questionnaire. That this is the 11 question that can identify the symptom of the nocturnal hypokinesia, and now it be translated to Korean language, not only English. And for the treatment, for the pharmacological treatment, there have the evidence of the long-acting dopaminergic medication like standard Madopa, HPH, sustained release, and also loticotine, ropinirole, and low of apomorphine for the treatment of nocturnal hypokinesia. And another problem is another management is you might advise to your patient is the rehabilitation to train the strategy of the getting out of bed, because the axial usually rigid on bradykinesia, but their limb can move better than the axial. So the strategy may be use the multi-step of the extremity to help to getting out of bed. And another may be assistive device or healthcare provider. So the last one for the take-home message, sleep and nocturnal problem in Parkinson's disease still be the unmet need area and unrecognized, and can present in both motor and non-motor. And the cause can be from disease itself, the treatment effect, or other general etiology, and it's occur in the nighttime, but it have the effect on the daytime as well. So thank you. If you want to join us in November, we invite all of you to join us at our movement disorder camp in Thailand this year. Thank you so much.